our next presenter, Dr. Andrea Knight. Dr. Knight is a longtime friend of the Foundation. She'll be talking today on Mind Matters, Pioneering Research and Strategies for Managing Mental Health in JM Patients and Their Families. Dr. Knight's a pediatric rheumatologist at the Hospital for Sick Kids in Toronto, Canada. She's also an associate scientist at the Neurosciences and Mental Health program at Sick Kids. She's an associate professor of pediatrics at the University of Toronto Faculty of Medicine. She obtained her medical degree from Columbia College in New York, then completed her pediatric residency and pediatric rheumatology fellowship at the Children's Hospital of Philadelphia. Also has a Master of Science in Clinical Epidemiology from the University of Pennsylvania. Dr. Knight holds many positions. It will take a while to go through them all, but she's the immediate past chair of the lupus section of CARA, current co-leader of the CARA mental health work group, and leads some other important mental health work groups in Canada. She's also the Canadian Rheumatology Association Research Committee Scientific Advisory Board for the Lupus Research Alliance, and she's on the Medical Scientific Advisory Committee for Lupus Foundation of America. It gives me very great pleasure to introduce Dr. Knight this afternoon to talk about Mind Matters, Pioneering Research and Strategies for Managing Mental Health in JM Patients and Their Families. Andrea, over to you. Thank you.
Thank you for the kind introduction and for the invitation to speak at this summit, and good afternoon to everybody here today. So I will jump right in. So I have no conflicts of interest to disclose. So the objectives for this short talk today are really to discuss the mental health impact for our patients and families with juvenile myositis, and also to discuss some of the research that's been going on, as well as some care advances to optimize mental health and overall health outcomes for this population. So the impact of juvenile myositis on mental health can be very burdensome. So we know that, like on the left, we have the different disease manifestations that you're all familiar with. So muscle weakness, rashes and vasculopathy, different complications, the long-term steroid use and other medication side effects. This can all contribute to mental health problems under stress and the burden of chronic disease and treatment effects. But we also have to think about how things like socio-demographic factors and even genetic and epigenetic factors contribute. So just to think about this broadly with this framework, we also think about how mental health problems can impact different clinical and psychosocial outcomes in the population. Things like disease control and adherence, healthcare utilization, transition to adult care can be affected. In addition to health-related quality of life, which most of us would think of, but also school performance, later work productivity, as well as peer and family relationships throughout the disease course. So some of the early work that's been done to try to understand the mental health impact was done by Dr. Polly Livermore. I don't think she's on the call today, but she is a nurse and researcher who really was able to characterize the mental health effects from a qualitative perspective, doing some interview work with patients with JM. And you can see here in the quotations, not being able to move, really wanting the aspects of the disease to stop, such as rashes, but also medical invasiveness. You see reference to a PICC line, biopsies, feeling sick, having to do physiotherapy, and really just, summarized by this quote of always feeling sad. And the other thing that was characterized from this work is what they call the JDM roller coaster, which I think is really helpful to think about in the disease course and context of over a period of time, the range of emotions that are felt through patients from diagnosis as they go through the treatment. So maybe initially things like feeling confused, like what is this that I have? What is this disease even? Feeling different because they're feeling sick, but also because they're having visible as well as invisible effects of the disease. Going through treatment, the effects of steroids, also feeling scared and uncertain about the future, and then periods of acceptance, accepting that, this disease has happened to me, this is what's happening, but really importantly, realizing that these things are cycling over time, that it's really, you need to think about it within the course and duration of the disease. So building on this qualitative work that Polly had done, we also were able to get parent perspectives on mental health of their children. So this was a focus group study that was conducted now only about 6 or 7 years ago, but published in 2020, where we asked 45 parents of children with juvenile myositis, how would they describe the emotions that their children were feeling? So this word cloud represents the frequency with which these different emotions were stated by the parents for how they thought their children had expressed these emotions. So anxiety, you can see, is front and center, the largest word. Depression is there, anger, loneliness. There's various mentions of different aspects of the disease, but also peer relationships are in there, family relationships. And I think in the top corner, one thing to remember is that there is mention of resilience. So there is something that can be improved upon to help with the emotional resilience of these children. So thinking about the themes that came out of that qualitative work, Dr. Ardalan, who I believe is on this call for this summit, was working very closely in helping to lead this effort with our team. With patient emotional health, you can see again this idea of how we need to think about it over the course of the disease duration between periods of high disease activity and low disease activity or remission, but also this concept of emotional health and trying to build resiliency and how it can cycle. But in addition to that, the parent and the sibling and family effects are really, really important to consider. And that came out very strongly in our parent interviews. I just include a quote here from a father of a JM patient that said, he wondered, how do I take care of my child? How do I take care of my wife? How do I take care of myself? Mentally, physically, emotionally, that's a lot to deal with from a parent's perspective. So we'll get back to this in a few slides, but I think it's important to remember that this is an impact not just on the child, but also on the family as well. So additionally, beyond the qualitative work, we wanted to get some quantitative data, because prior to these efforts in the mid 2010s, it really hadn't been characterized so much in juvenile myositis. So, we've been able to make some strides in characterizing this a little bit more. And one of the things that has been helpful is to do something called patient-engaged research, where we are involving patients and families and caregivers in the design of the research and the approach to the research. So one of these first projects that we did in collaboration with patient organizations such as CureJM and also the Childhood Arthritis and Rheumatology Research Alliance, or CARA, was a cross-sectional survey asking patients with juvenile myositis, what's focused on here, as well as other rheumatologic conditions, how much do they think they're having emotional health problems? So these are self-reported emotional health problems in these youth from ages 14 to 24 years. And what was quite striking is that we saw a lot of self-reported depression, anxiety, suicidal thoughts, self-injury, and so on that you see here. Now, the green bars are self-reported clinician diagnosis. So these are patients who said that I have a clinician, a doctor who's diagnosed me with this emotional health disorder, mental health disorder. But then in addition to that, the blue bars are showing additionally self-reported symptoms that had not been diagnosed. And again, pretty striking. We're seeing numbers here in the 40 to 50% if you add the clinician diagnosis and the self-reported symptoms for depression and anxiety alone. So quite striking in terms of quantification of these mental health problems. So another way that we were able to look at this was a multi-site study that was funded by CARA, and this took place at Duke Children's as well as the kids in Seattle Children's. And in this study, we actually were able to administer mental health screening measures to patients who enrolled in the study. These patients were aged 5 to 21 years, so this was going lower in age than the 14 years from the survey I just showed. And we wanted to know how many of these patients were screening positive for things like depression and anxiety, as well as internalizing and externalizing disorders specific on the PSC17 to patients less than 12 years of age. So along the x-axis, you can see the percentage of patients who screen positives. The PHQ-9 measures depression in adolescents. The scared anxiety measure is across the age span, but we did have parent measures for in the orange bars for patients who were less than 12 years old. And the PS17 was specifically for patients less than 12 years of age, and we had both parent and patient measures there, color-coded. And basically what we saw is that there were high levels, upwards of 50% for depression symptoms in the adolescents, scared symptoms approaching 50%, patient report for the patients across that age span, as well as those younger patients were having 20% of reported symptomatology. And what this equated to was 68% of this sample, which was 72 patient and parent dyads, actually had screened positive on at least one of these mental health screening measures. We found additionally that depressive symptoms were correlated to worse physical function and worse medication adherence. And that also, importantly, mental health screening was thought to be feasible and acceptable in this patient sample. This work was led by Dr. Ardalan. We've presented this work at several conferences, and manuscript is in preparation. Now, importantly, you might ask, well, what happens after the screening, right? So we detect these problems, like what are we going to do? So these patients were, there was an algorithm developed in terms of what to do with the screening results, and they were referred to mental health specialists based on their positive screens. And so we did a survey for those who had screened positively 4 weeks after the referral to see what happened. And we found that of the 49 positive screens, we had a response rate of about 50%. 25% had been seen already, or they were scheduled to see that referral specialist, but really 75% had not been scheduled. So, you might ask why, like, what are the barriers that are being encountered, where they're being identified, they're being referred, but they're not quite being seen. So when we asked on these surveys, the patients, like what, and the parents, these were actually parent responses, what had happened? Well, they said, the patient or did not want to go, or they felt uncomfortable going. That could have also reflected the parents' feelings on getting mental health support. They also said, though, that they could not find a qualified mental health specialist that was nearby. And maybe they found one, but appointments were not available, or they were just taking too long. The waiting list was too long. And that even they were unsure about whether the specialist would really understand JM. So just to think about this in terms of the larger landscape that we've been looking at, this reflects survey results across North America looking at CARA sites, CARA pediatric rheumatology sites, in a survey that had been done in 2016 across 2018. So really only a third of the 100 CARA pediatric rheumatology centers that we were able to contact had any affiliated social worker or psychologist. So this really parallels what we're hearing from the work in this multi-site study, and that a major gap in care that was identified by the social workers and psychologists that we were able to contact was that there was inadequate connection to mental health services and lack of follow-up on referrals. So even if we're identifying these kids, we have some work to do in terms of connecting them. So some of the work that myself and others have been doing is thinking about, well, how do we implement, so that was a research project, how do we implement mental health screening in a way in the JM clinic that is in a way that's effective and can lead to appropriate care. So funded by a CareJM mental health grant, we were able to do a project using quality improvement methodology, where we had a specific aim to increase the rate of mental health screening for patients, in particular for this phase, from 0%, so we really were not doing this outside of the research project, to at least 50% over a short period, and you'll see these results over the longer period. And additionally, in doing this, we wanted to ensure that the patients and their families who were screened had the appropriate mental health resources and referrals, and that they were also, we wanted to assess their satisfaction with the screening as part of their care. In order to do this, you can imagine, so in QI speak, we talk about primary drivers and secondary drivers, and it really refers to like, what does it take to do this and implement this? So we have to think about clinical workflow, engaging the clinical team, and engaging patients and caregivers. And the kinds of things that we had to pay attention to and implement were things like mental health education and training for clinicians, pre-surveying the patients and families to kind of see where they're at, programming of the screening tools, of course. We wanted to do this electronically, as well as documentation tools for the electronic medical record. And in order to make sure that the appropriate care was administered, we developed an integrated social worker care model. So this social worker, specifically, the role was to provide on-site psychosocial care in response to the screening results. And this entailed things like education and potentially different therapies for the different things that were identified. And I put in the bottom right corner here just all the people that were involved in sort of making this happen. So not just the rheumatology team and the research team and the social worker, but the physiotherapists and the nurses and patients and caregiver input as well to implement this. So the way this worked is that, so I say here, between January and October 2023, 73 patients were seen in the Sick Kids JM clinic. Of those, 64 patients were eligible for screening based on their age group, and their diagnosis. Of the ones that were eligible, 63 or 98% of those were screened, so that was really good. And this was found through patient and caregiver surveys to be feasible and acceptable. And again, we use these screening tools. The PHQ-9 and the GAD-7 were really for the kids who were 12 years of age and older. PHQ-9 is for depression and GAD-7 is for anxiety. We chose these tools because this is in the clinical setting and not the research setting. So we wanted a 9-item tool and for the PHQ-9 and a 7-item tool, very brief tools for depression and anxiety. And the PSC-17 we kept for internalizing and externalizing disorders in the younger age group, and that's 17 items. And what did we find? We found that almost a third of the patients had positive screens, so less than that multi-site study. But again, this is in the clinical setting, so a little bit different. So it's always interesting to see what happens between the research and the clinical transition. Just to give you a little bit more of a breakdown, you can see here the depressive symptoms by the PHQ-9, the anxiety symptoms by the GAD-7, and then the PSC-17 symptoms here. The number of patients is on the x-axis and the severity of the scores is on the y-axis. And what I want you to take home here is that, so the dark blue bars represent the patients that really had negative screens. So that actually is most of the patients, which refers to that 2/3, that flip of the negative screens that I was talking about. And then even with those in the positive screens, they had relatively mild symptoms, although some of them had more moderate and some of them had more severe symptoms. So we really saw a range of patient symptomatology. And I think, this really speaks to the fact that, yes, a third of the patients needed to be identified and I think would benefit from that identification addressing those problems. But I think that there's a lot of perhaps anxiety within ourselves as providers, like, oh, if we ask these questions, is everybody going to answer positive and what are we going to do? And we really didn't see that. So of those positive anxiety and depression screens, all of them were offered a social work referral and therefore assessment. However, several patients were already receiving services, which was encouraging. And this, I think, highlights the importance of the community providers and primary care providers, in addition to what we can provide within the clinical care setting in our JM clinics. But getting down to the social work sessions that happened, we had 24 sessions that happened among 6 patients. Mental health issues were further identified and defined. So we found that, there were definitely disease-related stressors that you can see here, and this parallels a lot of the qualitative work that I, was presenting before. But then there were other stressors, perhaps more, typical childhood-related stressors for school and bullying. But grief was something that came up a lot. Family issues were something that came up a lot, as well as sleep disturbances and traumatic incidents. So the outcomes of these sessions were that they were ongoing assessments in a few patients, really trying to monitor for self-harm. But there was also some implementation and learning of coping strategies, and we felt that these sessions were successful in helping to implement those things. And at the conclusion of the sessions, most of the patients really felt comfortable to stop their session. So there was like an endpoint to these sessions with a favorable outcome. And one patient was referred on to psychiatry and also connected to a therapist. So, this QI and implementation work actually served as a pilot data and selection of the JM Clinic as a pilot site for a wider hospital-wide mental health strategy initiative called measurement-based care, which consists of automated mental health screening. So we're very excited to be part of this. This involves electronic screening via an app that you can see there on the right, which is kid-friendly. This initiative is really restricted to adolescents, so those who are 12 and above. Importantly, though, it's automated. These patients are identified automatically to be eligible for screening every 30 days, and it's integrated into our Epic electronic medical record. This is just a snapshot of, our Epic dashboard, which actually has a mental health functionality. The scores are, the assessments are done on the app. That app feeds directly the scores into the Epic electronic medical record. So when we're a provider, we see these mental health scores. They're color-coded by severity. And additionally, I didn't show this here, but additionally, there's programming to say, what do you do with these scores? What are the action points? And if somebody flags off suicidal ideation, which is on the PHQ-9, there's specific algorithm and alerts for that. So this was launched in the JM Clinic this past summer. It was previously launched in our lupus clinic in December, so we had some learning experience there. But overall, it's been quite successful. And people might say, okay, but what are you doing with this automated screening and what's happening there? So when we have these results, there has been the support from a social worker that is specific to the measurement-based care or MBC program, but there's coordination with our clinical social worker. And the idea is that over time, we will work on, these referral and approaches for addressing the mental health screening results, but we're also generating data to advocate for more resources. So, I had mentioned earlier about the stress on the family unit and caregivers. One project that we're very excited about, and that is in development, and I would hope to give you results on in a future session, is our caregiver mental health screening project, which is also funded by a CareJM mental health grant. So in this grant, we really want to focus on caregiver-reported family well-being. We weren't doing this currently clinically, and so we are going to go from 0% to 50% within the year. And then we want to make sure, of course, that they're offered assessment, again, by an integrated social worker model. So what our approach is to do a screening for the caregiver assessment first. We're using something called the PEDS-QL Family Impact Model. This is a validated screening questionnaire, which looks at physical, emotional, social, and cognitive function, as well as communication and worry amongst caregivers. And then the idea is to drill down a little bit more on the specific needs in the context of peds rheumatic disease with an additional survey called the caregiver survey. And the role of the integrated social worker will be to review results, discuss with the parents or caregivers, to offer supports, whether that's referrals or sessions. So we look forward to sharing results from these projects in the near future. I also wanted to highlight other projects that are going on that my colleagues are working on, because I think there's a lot of active work in this space, which is really exciting. CareJM has been offering mental health grants. I think this might be the 3rd year in a row. I didn't list all the projects here, but I know my colleagues at the University of Minnesota and Seattle Children's Hospital, where Via Lannis was previously, were doing work on mental health education, as well as narrative medicine as an intervention to improve mental health and well-being in patients with JM. And then to highlight a couple of other studies, Polly Livermore at GOSH is developing a UK-wide intervention to increase caregiver education and well-being called the IMPACT study. And then Kaveh Ardalan at Duke is also developing an intervention to reduce stress and optimize cardiovascular health. So I wanted to highlight these things because it's very exciting that all of these projects are going on in this space. This is also in the backdrop of the larger CARA mental health working group, which I co-lead along with Dr. Tamar Rubenstein and Dr. Natasha Cunningham. We have developed a prioritized mental health research agenda framework for which to think about advancing mental health research and care for patients not only with JM, but other rheumatologic disease. We have been working on guided statements for our providers to how to address these mental health concerns. And we're actively working on the ACR, American College of Rheumatology endorsement and publication. So ask you to stay tuned for that. Realizing that clinicians would benefit from mental health education. Many of us did not really receive that so robustly in our training. We've been working on workshops as well to provide that education. And we've been in close collaboration with Suzanne Edison, who is on this session and who served as the mental and emotional health coordinator for CareJM. The last thing I wanted to mention, which I think is really exciting, is trying to look at the interface of like, what is going on with the disease and mental health? Is mental health simply a comorbidity, or could there be some inflammatory contribution? So I wanted to share with you a little bit about the work that I'm doing in the context of lupus initially, but now expanding to think about other systemic inflammatory diseases such as JM. So when we think about kids, who get these diseases, they're really at a vulnerable place in terms of their brain development. So what is the impact on the brain structure and function and development? Could there be a subclinical impairment that happens both in cognitive function and then also affective regulation or psychiatric disorders? And then in the context of lupus, we certainly see overt clinical phenotypes in terms of cognitive impairment and psychiatric disorders, but very interested in thinking about, could this be happening in other respects? So in the lupus population, we are conducting a longitudinal study involving lupus and healthy controls and collecting several different measures for neurocognitive assessment, psychiatric assessment, neuroimaging, blood biomarkers, patient-reported outcomes, and also socio-demographic variables. And we've just started to collect data for a pilot for JM patients. It will be a small pilot. We've already consented to patients, so we're very excited about this. But more to come in terms of thinking about, again, that interface between inflammatory disease and our mental health for our patients. So in summary, mental health problems are quite prevalent in children with JM and represent a significant burden for patients and families. We need to understand actually more about the caregiver burden. Mental health needs are currently under-addressed in JM, according to the research that we've been doing. But, really collaborative, multidisciplinary, and patient-engaged research and also care implementation projects can focus on intervention and hopefully help close this gap. And the third thing pertains to that last slide. I think that translational research is going to be really important to understand the relationships between mental health, JM disease and inflammation, and also outcomes for these patients. So with that, I'd like to thank the organizers again for inviting me, all of the people who've been involved in these research, patients and families, different organizations and funders. Thank you very much, and I will take questions.
Thanks, Andrea. Again, as the questions pop up, if you could read them out before you answer them, that'll help with the recording. Thank you.
Okay, thank you. Okay, so in terms of first question, Via, what intervention is planned if there is concern for acute suicidalization for the parents? So this is a great question. So this pertains to the Caregiver Mental Health and Wellbeing Project. So this has been definitely something of discussion. So currently, you know, the clinical social workers do deal with caregiver mental health concerns and crises. So right now, the current algorithm really is to, if there's something urgent or crisis, we are in proximity to an adult hospital. So that person might need to go across the street to get urgent care, or we are able to, you know, take some of our resources for our hospital resources to have further assessment to figure out, you know, how emergent is this crisis. Some of the other programs within our hospital have actually formed relationships with psychiatry on the adult side to deal with caregiver crisis and mental health concerns that pop up within the pediatric realm. So it's an excellent question. I would say it's a work in progress, but as we begin to really address these issues more systematically, it's something that will definitely need more of a structured approach. Lucy, so the question is, how similar do you think these data are for those living with lupus and scleroderma and JM? So, you know, I think that when we look at the overall prevalence of these mental health, if we think about them as comorbidities, which may be questionable depending on what we see, I think that the prevalences are kind of, the frequency is kind of similar. I think, though, that it's a little nuanced in the sense of, well, what could it be due to? Is there a component due to inflammation? How much of this is due to maybe different types of medical trauma that have been endured? How much of this might be due to different socio-demographic and socio-environmental situations? So I feel like the more that we look into this, the more complicated it gets. And I think what I would say is, even on the outside, if the frequency looks the same, it's not a one size fits all. And I think that's really important to think about, okay, well, what intervention, like what's going to help them ultimately? If we can understand better what's contributing, then we can be more targeted in our approach. Let me see. Don't see any other questions. And I think time-wise, we probably need to move on, but thank you so much for your attention, and please let me know if you have any other questions.
Thank you, Andrea.